it is the curative setting, and this is our chance to cure the disease. I think it can be challenging to talk about a treatment that has a rare but potentially fatal adverse effect with
Absolutely.
ILD, but I also think, as you've pointed out on the flip side, it is the curative setting, and this is our chance to cure the disease. So we should lead with our most effective therapy to cure the disease.
Absolutely.
Well, let me ask you a little bit further. You've nicely commented on the patients who qualified for the trial.
Yes.
Now, when you're sitting in clinic, or how would you counsel our colleagues in terms of patient selection for adjuvant T-DXd? Are you offering it to everybody with residual disease, or are you sticking to the trial criteria?
Right now, I think I'm sticking to the trial criteria. The reason I also say that is, if I am seeing a patient who's just newly diagnosed, and if I can apply the DB11 criteria as well to that patient population, I think that's a reasonable approach to do. Because, as we said, we're sometimes not trying to hold back to therapies at the back end. We're trying to use our effective therapies up front as well. 4 cycles of T-DXd followed by THP at DB11 definitely gave me a very respectable PCR rate. Yes, we don't have the EFS data, but we also know the totality of data with T-DXd. From the metastatic setting, from brain metastases, from DB05, I feel like we know that this drug is effective. We know that this drug works, and it's a very respectable PCR rate and very early trend of EFS that we're seeing. So I do think that it's possible that I'm going to offer the DB11 strategy. And because I would do that, I feel like I am right now thinking about offering the DB05 strategy to the DB05 eligible patient population.
Yes, that makes sense. And I want to talk a little bit about a point that you raised, and that is the CNS activity.
Yeah.
I think we were excited to see the overall survival data from Catherine, as you've highlighted, but also a little disappointed to not move the needle further in terms of CNS recurrence in Catherine.
Absolutely.
Now, when we look at DB05, what are your thoughts about the potential CNS activity in the preventative setting?
Yeah, no, I think that's such an important question. And in fact, something that we saw in the readout as well from DB05, that not only did we see, IDFS, DFS, but we also saw some distant recurrences, including CNS recurrences, favoring the T-DXd arm compared to TDM1. And that's where I think the Catherine data fell short a little bit, that we did not necessarily see that. We still saw 5% of the patients with CNS as the first recurrent site, but it was encouraging to see that at the current readout itself, we're able to see that. Not surprising also, given at least we've seen robust activity in CNS metastases for treatment purposes. We don't necessarily have a lot of prevention data yet with T-DXd, but to see that there were improvement even in CNS recurrences in this data set was very encouraging to see. We have trials such as COMPASS residual disease through the Alliance that is ongoing, where patients get THP, could get anthracycline, but for residual disease, they then get TDM1 plus tucatinib, which is a TKI, and we can expect activity there, but maybe expect activity for prevention. We'll see what that readout looks like, but I think it was very impressive and encouraging to see even impact on CNS recurrences with the DB05 data set.
Absolutely, very, very exciting.